Well, thank you very much, Jay. I appreciate that kind introduction. It's good to see all of you today, and those I can't see. Thank you for being with us today. For the first 15 minutes or so, I'll just give a general update of where things are at. As In the world of COVID, things change quickly. But before I do that, I want to provide you with one disclosure I think that's very important. I have nothing to disclose from a financial standpoint, but I think what you need to know is I actually believe I probably know less about this virus today than I did 6 months ago. And unfortunately, the more I learn, and I think more we learn in general, the more challenging it is to understand exactly what it's doing, how it's doing, and where it's doing, and what the future may hold. Let me just start on the international level first, and then I'll talk about what's happening domestically. At this point, we are in the darkest days of the pandemic globally. The last 3 weeks have basically had about 5.7 million new cases reported per week to the WHO, has peaked out in terms of the numbers that we've seen prior to that, before the January peak that involved a number of European and US here. European countries in the US got us to about 5.1 million cases reported per week. Why is that happening? Well, surely you're well aware of what's happening in India and now Nepal and Pakistan. But what most people don't understand is the fact that if you look at, in the sense, the hottest spot in the world is actually in South America. Uruguay has reported the highest incidence of cases anywhere in the world multiple times over the past several weeks. And we're seeing in Uruguay, Paraguay, Chile, Peru, major activity, as well as that in Brazil. We're also seeing now unprecedented activity in the Southeast Asian countries, Vietnam, Cambodia, Thailand, even Taiwan, which now is going into stage 3 of a fourth sector lockdown, which is a country that's been heralded for its work in suppressing and keeping the case numbers down and living, in a sense, a normal life in the world of COVID. And today they're having challenges. Where you have been following the Olympics, you know what's happening in Japan. Even China is starting to see some increase. Indonesia, Malaysia, all are experiencing major increases. If you look at other parts of the world right now, Iran is now going through its fourth surge that it has had, and the case numbers are literally at an all-time high in Iran for the entirety of the pandemic. Things are improving in Europe, where B117 variant, and I'll talk more about that in a moment, really caused major challenges there. Just to give you some sense for those that haven't followed it closely, but what England went through in December and January, to put that in some context to the United States, if you had actually taken the number of hospitalized patients in England in January, that would have equated to about 195,000 hospitalizations in the United States. We got to 130,000 hospitalizations in January, and we were literally in many locations house on fire. So you get a sense of what happened there in Europe. In terms of where we're going internationally, right now vaccines are in very, very, very short supply for the low and middle income countries. And this is a huge challenge for us for two reasons. One is obviously the humanitarian aspects of vaccine, but also very important is the preservation of our current vaccines that we're using. And as you know, the variant situation is a challenge to understand just how much impact that some of these variants are having is yet unclear, but it's surely impacting the vaccine performance in some ways. Whether it is the fact that we're now seeing breakthrough infections with symptomatic disease, there's still, I think, general evidence that it is still reducing serious illness, hospitalizations, and deaths. But it's going to be imperative for us to really make an international priority to vaccinate the whole world's population, given the challenge for manufacturing and distribution of vaccine that still is going to be a priority. So what's happening in the United States? Well, we've really gone through a series of events that I think today we can't really explain. I think that people believe that we're having more impact on this pandemic than we really are, other than from the vaccine standpoint. And what I mean by that is if you follow the course of this pandemic, remember last April, when we had areas of the country, Boston, New York, your location, Chicago, Detroit, and New Orleans, Atlanta, southwestern United States, and the Seattle area, we got up to about 32,000 cases reported a day. In many parts of the country, there was relative absence of cases, counties that went for weeks and weeks and weeks and didn't have one reported case. Well, those case numbers dropped to about 20,000 cases per week by Memorial Day, and people were feeling, okay, this is the pandemic, okay, we're kind of done. And then, as you are so well aware, in July, we saw a major increase in cases. We got to about 70,000 cases reported a day. The southern Sunbelt states were on fire, from California all the way to Georgia. And it was a huge challenge, particularly in those states. Well, then that basically subsided, kind of hit a new baseline low where we got down to about 26,000 cases a day, and we're feeling pretty good. We're down there now. And that got us to September. And then we saw in mid-October the upper Midwest, particularly the Dakotas, Minnesota, Iowa, Wisconsin, to some degree you in Illinois, Michigan, and Nebraska all lit up. And even though we only accounted for about 12% of the country's population, we ended up basically getting the case numbers up to about 200,000 new cases reported a day, largely from this upper Midwest surge. There was over a 10-day period where North and South Dakota, respectively, had the highest incidence of disease in the world. Then that subsided, and we saw case numbers coming down. They only came down to about 150 to 155,000 cases a day, which is kind of a new low baseline. And then the southern states picked up again. Those same southern Sunbelt states that lit up in July are now lighting up in late December into January. And on January 8th, we got to 300,000 new cases reported a day from those same southern states. And then that subsided substantially. And at that point, I think people were beginning to feel like, well, we're over with it in this country. We now have vaccines. I think the vaccine story has been an amazing story in of itself. I surveyed on the Biden-Harris transition team for COVID-19. I can tell you that we had many discussions through the month of December based on what data we had from the pharmaceutical manufacturers. Would it be a reasonable aspirational goal to try to deliver on 100 million doses of vaccine in the first 100 days of the new administration? And there were some real questions about that. And yet, by the time we got through those 100 days, the administration had delivered on 220 million doses. And today we're now well upwards in 270 million doses delivered. That's got to be really, really good news, and news that would make us seem like, well, we're just about over with this thing. Yet let me remind you, you know, you were close enough to the action to understand what went on in Michigan in April. Here in Minnesota, the same thing. I can honestly say I have never seen in my entire career a respiratory pathogen, viral in nature, do such damage as it did in Michigan and Minnesota, and yet spare much of the country. Originally, we had anticipated that the B117 variant, the one that has been shown to be 50 to 100% more infectious than previous variants and work in England, and also a lot more likely to cause severe disease. When we saw what it did in Europe and now has spread into a number of locations around the world, and in each instance, it becomes the dominant variant very quickly, and also we believe with this increased transmission. I can tell you here in Minnesota, we saw the difference between night and day in transmission with regards to kids. For example, just a simple fact, at the height of the November peak here in Minnesota, over the 2-week period, we had 761 schools that had kids with COVID-19 in it. In only 20% of those schools did we see multiple cases or evidence of outbreaks. When we then looked at what happened in April, when B117 was what was driving it, we had 790 schools, not that much higher number, but in fact, in those 2 weeks during that time period, over 80% had outbreaks or multiple cases. Again, demonstrating a much, much higher risk of transmission to kids, by kids, into the community. But with vaccines coming on board, of course, we obviously all have been very, very excited about that. Today, I just report that we have 46% of the US population with fully vaccinated, 34% with one dose for the Pfizer Moderna vaccines. We have, if you look at those 18 and older, we have 55% of the population with one dose, 44% with full doses. And the good news, if there is in any of this, is the over age 65 group, where we have 83% of the population with at least one dose, 71% with two doses. But when we look at what's happening around the country, it's like the tale of two cities. If I look at the states of Idaho, Wyoming, Arkansas, Louisiana, Mississippi, Alabama, Georgia, and Tennessee, they're all at the very bottom rung, where 6 of these states don't even have 45% of the population with one dose, and all of these have less than 50% with one dose of vaccine. And we're seeing this big disparity within states, even with higher vaccination levels. We surely here in Minnesota are seeing challenges right now in our communities of color in particular, in terms of getting vaccine there. And I just share this with you because none of us can understand why B117 in April didn't take off around the world. As I said, I've never seen that happen before. Here was Michigan, a house on fire. Indiana sat right next to it with some of the lowest vaccination levels in the country, and we saw no activity at all. When's the last time you ever saw one state turn on fire with flu and no one else around it did? And so this is a challenge for us to understand what's going on. But I also want to leave you with a cautionary tale. Right now, the Seychelles, a country of 100,000 people off the coast of Africa, is the most vaccinated country in the world. Over 70% have one dose, but 58% are fully vaccinated. Now, they're using the Sinopharm vaccine and the Indian AstraZeneca vaccine. But with the results they're getting right now, it shows them to be somewhere in the 80% plus level of protection against symptomatic disease with the vaccine. Yet, just in that 30% that doesn't have any doses, and among the group that have just one dose, they are now in an outbreak such that they're in total lockdown. And it's the Seychelles. They're locked down right now with those vaccine levels. And the vast majority of the transmission that is occurring among that smaller group that is not yet vaccinated. And I think it points out that we have to be very careful to assume total victory yet here in our country, let alone the world. Because in fact, I think we do have pockets here in the United States that could easily flare up tomorrow. And we keep seeing new variants. As you're well aware, there is a new variant now out of India, the B1617, and now we actually have 0.2 and 0.3. Just in the last week, 0.2 looks as if it is spreading even much faster than B117, and at least in 3 locations, it has become very quickly the more dominant variant, even surpassing that of B117. So I think to summarize it, we still have a lot left to learn here. We still have a lot to understand how these vaccines will work over time with variants, what the acceptance of the vaccines will be, even in a country like ours. As I was pointed out, and I do this weekly podcast, and I covered this a few weeks ago, there is no way in Sam hell we're ever going to hit the concept of herd immunity in this country. That was a pipe dream from the beginning. Why do I say that? Classic herd immunity, as an epidemiologist, means that there is sufficient vaccine-induced immunity or natural infection-induced immunity where you actually can stop the virus from continuing to transmit over time, much like a reactor with reactor rods in it as a virus. And once you have less than one new case for every person, eventually you see the numbers going down and down. Well, with a disease like measles, we know you have to get to 92, 94% with some uniform mixing of protection and not just an individual group that might in that 3 to 5% live in the same neighborhoods or socialize in the same places, et cetera. Well, with what we're seeing right now with these variants and the transmission characteristics, I'm not sure it's as high as measles, but it's much higher than the 65 to 75% that we once saw. We have seen just dramatic transmission in places where it has taken off. And then you add into that the fact that the vaccine, as good as it is, in an effectiveness level, I think we'll all be quite satisfied at 1 year if in fact it's in the high 80% level of protection. Remember, the original vaccine trials, which gave us the efficacy data, really relate to ideal conditions for who might respond, who is not at risk. Nobody accounted for the 12 million Americans who have some level of immunosuppression or immune deficiency that might challenge their ability to be protected. It doesn't count the number of people who are among the fragile and the frail elderly and who are experiencing immunosenescence. So when we get that vaccine out there, I still think it's going to be a great vaccine, but it surely is going to be less than 100%. And then finally, you add in the vaccine hesitant. And we're still seeing up to a third of the population really resistant, reluctant, just not outright not going to take the vaccine. So when you add those together, we can still do a tremendous amount with our vaccines to hold down transmission, but it's going to be with us. This is not going to go away. And whether it becomes a seasonal virus or not, I don't think anyone knows. Anyone who tells you this is already becoming a seasonal virus, I would challenge them to show us the data. If you look at the southern and northern hemispheres right now, we're seeing transmission on both sides of the hemisphere. That equator is not changing really what's happening. So I think we've got a ways yet to go before we have evidence of what the next hand of this virus will play out. So with that kind of overview, Chad, I'll turn it back to you, and very happy to take any questions, comments. As I said earlier, I think I know less about this virus now as I've learned more. And one of the things that this pandemic has surely taught me, the older I get, the more vulnerable I am to learning. So I look forward to your comments.
Great, thank you so much. That was a great overview. Just to start off with, I'll open it up to anyone here on Zoom that has questions. If not, I can kind of jump right into some questions that have already been prepared. Yeah, Dr. Ivy Brown, our Director of Ambulatory, has a question.
Hi, thank you.
Thank you.
I was just wondering your opinion on how ready is the U.S. to really detect trends in variants as they occur? Because we're hearing this data, a lot of it coming from variants that are being detected overseas. I would imagine, given our case disease burden, there has to be some variants that may be U.S. born, and maybe we're just not detecting it. But I would love to hear your viewpoint on that.
Yeah. Well, thank you. That is a very important question. And let me just say that our ability to detect variants and understand them is improving each day. The CDC is ramping up a national surveillance system for that. And one of the first and foremost important things they're doing is looking at vaccine failures to understand, is that a variant related issue or is it something to do about the host? There's been some debate about that because initially they were only looking for people who were hospitalized or severely ill. And if you know anything about the sequencing in terms of the CTs and the PCR, you do have to have lower CTs to actually be able to sequence the virus. But now I think you're going to be hearing very shortly CDC announcing that there's going to be a major effort in each state to actually follow up on all reported vaccine failures if possible. And of course, foreign travel is very important. Our state in Minnesota picked up the first transmission of P1 in the United States as a result of people who had returned back from Brazil. So this is a really important question. And it is one where we have had our variants. We've had variants in New York, the B1526. We've had the variants in California, the 1247, the 1249, which interestingly enough came and kind of went. B117 started to really, in a sense, beat them out as we see it. We now already have B617 reported in the United States, the Indian variant, including .2. The one that is of even greater concern about that. So it's hard to keep up, frankly, with the emergence of the new variants and what they mean. Are they really variants of concern? Are they variants of interest we might need to follow? And I think, again, falling into those buckets of either more transmission, more severe disease, or the ability to evade immune protection. This is a wide open area. I mean, I don't need to tell you all this. Think about this back in November. We thought of variants like all of them were the same car. Some were just red, some were blue, some were yellow, some were green. And now we surely do ascribe very critical aspects of health outcomes to these variants and the public health epidemiology. So stay tuned. This one's not over with by a long shot as regard to the variants.
Thank you, Dr. Osterholm. I happen to have been a trainee when the HIV epidemic started. And I remember at the time very similar uncertainties, scares, people being very uncomfortable with all the uncertainty surrounding the epidemic at the time. And then the evolution of our thinking, our ability to deal with the disease, how we moved from having HIV units to being able to take care of patients longitudinally anywhere in the hospital or in clinic. And I can't help make this analogy to the COVID pandemic, where when it started, we kept thinking it's the 100 meters dash. We're going to just get through it, one shot and done. And we kept moving the goalpost, maybe this is the 200 meters, the 400 meters. And now it seems like it looks like a marathon, and the disease is going to stay with us for years, and we're going to move from having COVID units to maybe being able to take care of COVID patients anywhere in the hospital and having post-COVID clinics. Is this your sense of where the pandemic is going, and should we prepare our psyche accordingly so that we stop thinking this is going to be done soon in July, August, September, or whenever?
Well, thank you. That was what I would call a wise comment, as much as it was a very thoughtful question. I think it surely does speak to our experience in the past and what we can learn now. So a year ago, on March 10th, I was on a podcast headed up by Joe Rogan. Some of you may be familiar with this. He's one of the more popular podcast people out there today. Unfortunately, he's gone rogue on us on this issue. But on that podcast over a year ago, I said I predicted that we would see probably 480,000 deaths at least in the United States, and it would last. This pandemic was going to last at least for 18 months. And at that time, as you kind of pointed out, people first thought this was a 100-yard dash. You should have seen my email light up. It was remarkable. There was actually even a major medical journal that ran a full one-page pictorial cartoon of comparing COVID against flu. And at the bottom of this long article, kind of side-by-side facts, they concluded that flu is much, much more important than COVID would ever be, and that we not be distracted off of what was really most important. So I think we have come a long ways to understanding just the dimensions to this. But, one of the things I think that's been important, and with the recognition, if I heard it once, I heard it 1,000 times. If we just were like India, look how well India is doing. Look at what Sweden is doing. Look how good they're doing. And you've seen in both countries this major explosion of cases and the challenges that they have there. I think this has been part of the humility that we need to have as a scientific community to say, there's still more surprises here. We don't know what they are. Now, I do believe that the vaccines we have, the mRNA vaccines in particular, are remarkable. And if we can keep from having the variants compromise those, and we can get enough people vaccinated, I think we will see, this becoming a very, very different disease. Now, what do I think the chances of that are? Given what I talked about earlier with regard to the variants, with regard to the issue of the population and the public willingness to actually, get vaccinated. And then with the fact that these vaccines are not going to be perfect, as the clinical trials almost gave us the sense. I said to myself, when you looked at the new Pfizer data that was just submitted for the approval process for the 12 to 15-year-olds, you saw that they said that they had 100% protection in the kids. They really did. They had no cases in the vaccinees. They were all in the placebos. Can you imagine the story of the first child infected after having received the Pfizer vaccine? It's not 100% effective. Well, we all knew that, but the expectations are it's going to be that way. But having said that, I think with the vaccine, we can do a lot to knock this down. Do I think we're ever going to get back to normal? No, we're going to have a new normal. Today, you're going to hear later, in fact, within the next 2 hours, CDC is going to be announcing that those who are fully vaccinated no longer need to mask indoors or outdoors. You're going to see this evolution of bringing us back to a more normalized state, but it'll still be a challenge. And part of that will be related to the variants, and part of that will be related to who gets vaccinated and who doesn't. So we're going to have treatment needs. I think you're going to see some major changes or improvements in our therapeutic regimens we have. I think small molecules are going to become much more commonly appreciated therapeutic agents, not so much nearly the immune therapies we've seen. So I think that all is going to help us. But in the meantime, it's still going to be here. Now, one of the areas that I have raised, in fact, I talk about this in this week's podcast, on an average year of influenza in this country, if you take the last 10 years, the median number of deaths each year was about 38,000 deaths due to influenza. Now, clearly that gets bunched up in a season, but if you look at that, that's about 104 deaths a day that occur from flu. You know, we don't shut down businesses very rarely, if anything, for flu, unless it's a pandemic. We don't close schools unless we have big outbreaks in grade schools. We don't mask. We don't tell people not to travel. We don't distance as such. We do encourage people to get their flu shot, which only a very limited number do. And I think we're going to find ourselves coming back more to that flu-like model. At what point, how much will we accept of COVID as the occurrence that it is and is going to happen? And how do we feel as fully vaccinated people being protected? The last piece I would just add on the vaccines, this is an area that people want more information, understandably so. Will we need a booster? Well, let's be clear, we understand what a booster is. It's the same vaccine used to boost your main immune system again. I often use for adults the example of Shingrix as a 1-dose, 2-dose booster kind of vaccine, or is this going to be more like influenza, where in fact, when we do see these mutation changes occur, at some point we're going to agree you need an updated, a new mRNA dose that is specifically addresses the mutation changes that are there. And I don't think we have any evidence yet of either one of those, if we'll have to do that. If we do, which one will we use? We do have some data that just boosting surely can enhance protection against some of the variants over the previous 2-dose regimen. So, but I think that's going to be left up in the air at this point. So I would agree with you. I think that we're going to see a new normal someday, and it's still going to include COVID. It's here now. It's not going to go away.
Hi there. Thank you so much.
Thank
This is
you.
really, really educational. I was wondering, you know, I'm reading a lot about how they're trying to potentially get the drug companies to drop their patents protection. And I was wondering if you see this happening worldwide, because I'm a bit cynical about that. And then do you think masks are here to stay in the hospital, whether it be seasonally or just all the time? Thank you.
Yeah, thank you. Well, let me just say, as you know, the Biden administration has indicated that they're going to push the World Trade Organization to, in fact, release the patents or the intellectual property information on the vaccines for the low and middle income countries to use. I think this is really a misplaced effort. Like you, I'm very skeptical. This is not about IP. This is about manufacturing capacity throughout the world. And we don't have it. We simply don't have it. The one country that was expected to provide more doses to low and middle income countries was India. And of course, now they have basically prohibited any vaccine to be moved outside of the country until they're able to vaccinate their own, which is going to take some time. So COVAX, the organizational structure brought together by the World Health Organization, the philanthropic organizations under countries of the world, really are still at a loss for what to do. If you don't have the manufacturing capacity, you can't build that overnight. I mean, just like saying we want to, double the hospital size you have. So by next Wednesday, we'd like to have that done. The second thing is look no further than expertise. What happened in Baltimore with Emergent? That was a brand new, incredible plant, but they didn't have the expertise to run it. And today we have a major shortage of experts around the world that are in the position to actually run these plants and make them work. So I don't think it's about IP. Most people are not aware of the fact there are over 50,000 steps in making an mRNA vaccine. It is really, really complicated. There are so many different items, factors, chemical constituents that need to be brought to bear. For example, one of the things most people didn't understand, why did the Biden administration get the kind of return on the number of doses in that first 100 days? Because they work closely with the companies to understand every single step of their process And where were the limiting factors? One of the limiting factors was a certain kind of filter. They just couldn't get their hands on it enough. So the government actually put in place the Defense Production Act and basically made it possible for the manufacturers to get rapid and increased amounts of these filters. Something that's simple. It wasn't about IP. And so I think that in the end is a certain element of IP that's related more to the political elements and people believing that big pharmaceutical companies are benefiting far too much. You know, you can have that discussion. I just want to get vaccines out. And that's not what it is. It's going to be manufacturing. It's going to be expertise. And then finally, you know, and I call that the Manhattan Project for the low and middle income countries, but they also need a Marshall Plan. If you think we have problems in this country with vaccine hesitancy and resistance, it's just as real around the world. And so we need to start working now to make certain that efforts are underway to help bring together communities around the world to get vaccinated. And you may think, well, with all these serious disease problems, that won't happen. Well, you know, you won't have vaccine hesitancy, but we've already seen it. So I think that it's really, really important that we push that forward. As far as the issue around respiratory protection, you asked about masks. You know, it's a challenge here. I one of my podcasts a year ago, last April, I challenged the notion of just how good mask protection was in preventing the transmission of this virus. Not because I'm against that, it's quite the opposite. It's the fact of having adequate protection. And some of you may know I was one of the main signatories to a document that went forward to HHS on the issue of aerosols. We also were dealing with that with regard to the WHO, and both WHO and CDC in the last month have now acknowledged the important role of aerosols. And we have amazing amount of information now showing the airborne transmission issues around that, and the fact that some people are highly, highly infectious, others are not. And so the challenge is going to be, what kind of protection do you need? And, you know, when we look at face cloth coverings and gaiters, for example, and these are actually data from NIOSH, which we've expanded upon them, they have over 50 to 60% leakage as face cloth coverings with aerosols in or out. You know, that's fine in terms of reducing your risk, but if you're in a area with that virus for an extended period of time, the amount of protection afforded by that face cloth covering is easily overcome. And so what we haven't had is a really legitimate, I think, full-fledged discussion on that. And I would just say that CMS has been doing a ongoing evaluation month by month. These are published in the Annals of Internal Medicine review on respiratory protection, fully supporting the N95 respirator protection, but showing that there still in their mind is not yet one well-designed comprehensive study looking at mask protection as such. And I know that goes counter to what many people would say or think, but I think it is true. I've looked at these studies over and over again, and while there's a number of studies reporting the protection of masking, I think it's really a challenge. Now, what's interesting to me, and you all can understand this point, none of these efforts have ever talked about how to wear the mask or the time distance. You know, if I walk into a room, 20 by 25 foot room, and somebody's smoking, I don't care what corner they're in and I'm in, you're going to smell the smoke. That's an aerosol. Well, if I'm in there for 25 or 30 minutes with my face cloth covering on, smelling it, that's a dose issue. And we have never once made a recommendation about how you use masking with regard to dose. You know, what extra protection does it afford you over time? And we did a survey here at our center in which we actually went on random news shows and looked at public settings to look at how many people were wearing face cloth coverings and how they wore them. We found 26% of all the individuals wearing a cloth face covering wore it under their nose. You know, kind of like fixing 3 of the 5 screen doors in your submarine. You know, again, no attention really paid to that. So I think respiratory protection is a very, very important issue. And I think as we get further into this, we're going to see that very issue of what that means.
Great. Just to kind of dovetail off some of those answers, you discussed kind of the limitations in the manufacturing. throughout this pandemic, have we learned something that we have not learned from other pandemics or pandemic simulations that we now think is important that we will need to plan for in the future for future pandemics?
Yeah, I think with this pandemic, it's like an old 727 going down, and it's got 472 black boxes on board. Every one of them need to be evaluated because all of them are teaching us a lesson. Let me give you one right now that we're watching very, very carefully, and it plays out, and this has everything to do with you. Our center started a major project 4 years ago looking at drug shortages, and particularly we started out around the issue of antimicrobials. We expanded that, and after a consensus group was brought together, we came up with a list of 156 drugs that are considered critical life-saving drugs. You know, what's on the crash cart, what's in the ER or the ambulance rig, you know, what's in intensive care. And those 156 drugs, 100% were generic. And of those generic 156 drugs, virtually all of them were made outside the United States. And with very fragile supply chains. In some cases, we had up to 60 of the drugs that had spot shortages or major shortages over the course of the last 4 years. Interesting enough, we're the only group in the world outside of the government of New Zealand that is doing this, and we collaborate a lot with New Zealand as we work on this project. Well, the reason I bring this up to you is that right now, the major pharmaceutical manufacturing activity in the world for generic life-saving drugs is in 3 different states in India that are under siege right now. We know that we have 4 to 6 weeks supply coming through pipelines for these drugs, but after 4 or 6 weeks of not putting anything on the other side, we don't know quite what's going to happen yet. And so we're monitoring this very carefully and very closely because one day you're going to potentially find yourself counting on any number of different drugs that you think should be there that are just going to be in major shortage supply status. And so I think that's an example of no one thought about that. And if you look no further than our own military, they themselves have no more access to these drugs than anybody else. So if you're talking about national security, you know, how could you let your military get like this? You know, we surely plan for missile systems and so forth for redundancy and production capacity. Here you're talking about, you know, the troops and force the troops and what's happening. So I think you're going to see a lot of things like this become very critical in terms of thinking. I think globally, you're going to see something as simply as important as just the availability of oxygen. You know, no one had really anticipated how many locations in the world would be so adversely impacted in a pandemic like this for the need of simple oxygen. And so, yeah, I can only say that there are going to be many, many lessons learned. And hopefully we will, because this is not the last of the pandemics to occur. You know, another flu pandemic could happen tomorrow. We've had 11 of them in the last 250 years. They're not going to stop. And now we realize the potential for coronaviruses to do this. And we still have a number of progenitor viruses out there in the coronavirus family in the animal population that tomorrow could give us, you know, SARS-CoV-3.
Yeah, that's certainly a scary reality. We have a question from Dr. Trantafilo, who's one of our geriatric specialists. He has, have there been thoughts on how to integrate education and delivery of care across the U.S. to address a pandemic? For example, can firefighters, police, clinicians going to patients' home to immunize patients for COVID-19, is there a method to integrate such a process at a national level to reach more people?
Yeah, thank you for that question. Right now, at every local public health level and in concert with the medical community and many other players, community health clinics, pharmaceutical venues and pharmacies, et cetera, there's tremendous planning efforts going on to figure out how to almost do what I would call vaccine house-to-house warfare. You know, how do we find the people who aren't vaccinated and which ones of those are access only, meaning they want to get it, but they aren't able to get to someplace. They can't make the 3 changes on buses that would be required to get to the clinic that they should go to. So there is a real effort going on right now in every location to deal with that. And it varies across the spectrum of the communities of color, essential workers, you name it, what we looked at. I think the bigger challenge is not that. It's how do we educate those who are still reluctant to take the vaccine? And what level of reluctance is it? For example, we have found among pregnant women a relatively high level of concern about the safety of the vaccines with their unborn child. We're still seeing that in the healthcare setting. We had 320,000 estimated female healthcare workers when this vaccine first came out who were surely concerned about this. And over a period of the first 2 months, we still had over a third of them who had refused to get vaccine. We have young Black men in the inner cities who are convinced this is just an extension of Tuskegee. That in fact that the horrible things that happened to those Black men in that syphilis study, well, this was just part of the government action. You'd say to yourself, how can they believe that? Well, they believe it. And therefore we have to address that issue. There are those who say, wait a minute now, run this one by me again. This was Operation Warp Speed. That doesn't sound like a good name for safety. The military was heavily involved with it. And there may have been somebody's thumb on the scale to get these approved before or after the election. And oh, by the way, this is that messenger RNA thing that we all know Bill Gates wanted to put the chip in us. And you say to yourself, how can you believe all that? Well, they do. And so the bottom line message is how do you help educate that group to understand the safety around these vaccines, why Operation Warp Speed was a very unique approach, very costly approach, but it provided us the safety that we now have over 250 million doses of this vaccine delivered in this country. And surely with the mRNA vaccines, this amazing safety profile. And even from a relationship standpoint to risk, even the adeno platform vaccines are really quite safe. So I think the challenge is making certain that we have culturally sensitive, politically sensitive information that we can provide to people that is factual, that they can trust, and the provider that can trust it. One of the most successful programs right now in the country dealing with young Black men that I just mentioned is a program that I'm quite involved with at the University of Maryland. And it's called the Black Barbers and Salon Program. And what the School of Public Health has done there under the leadership of Dr. Stephen Thomas, one of the premier public health leaders in our country, has been over time educate the Black barbers and beauticians as to a number of safe health issues, hypertension, diabetes, et cetera. And over the course of the last year, they've worked extensively to educate them about COVID and the vaccines and all around it. And so whenever you come sit in one of their chairs, you're going to get, a back and forth on this. And we have seen among that group a major conversion of people who said, no way am I going to get vaccinated, to eventually get into the point of getting vaccinated. So we need more programs like that. We need more ways to get people vaccinated. And then, to understand that over time, they may need to get revaccinated and what that means. So to answer your question, there is a lot going on right now, never nearly enough. And we do need to get these vaccines into physicians' offices so that as visits come up, just as you do now, you may see a patient for condition A, but ask and inquire about B, C, and D because they're all relevant. And you may ask, have you gotten your vaccination yet for COVID-19? And this was a great way to do it right now.
Yeah, I think you bring up a lot of really important points there in terms of the groups that haven't been vaccinated yet. There's certainly a distinct group of vaccine hesitancy that are still kind of in the window of being persuaded or dissuaded. And then there's the group that that doesn't use facts, reasoning, or logic to come to conclusions. And then building bridges to the community, I think, is a very important way of getting the people that have the vaccine hesitancy to become vaccinated. but also on that front, there was just a paper published in the New England Journal of Medicine yesterday discussing the infodemic and how do we combat the infodemic on a national level. And one of the ways I think that has worked nicely in the past with the barbershop model, but is there a different or another approach to combating misinformation and distrust in science and healthcare systems, similar to how we have, the FBI evaluates national security threats? We've seen through the pandemic, misinformation has been spread to 18 million people in a 30-minute TV program, depending on who's speaking.
Yeah.
Is there some thought of that actually being a national security threat?
Yeah, again, a great point. Let me just put some context to this that I think is hopefully helpful. I've been in the trenches in public health and infectious diseases for 45 years. I was very involved with HIV/AIDS. I actually was one of 12 attendees at the very first meeting the CDC ever put together on this rare Kaposi sarcoma, a pneumocystis cranii in gay men in LA and New York. We here in Minnesota were on the cutting edge. We were the first state and first government body in the world to make HIV reportable as a way of understanding the epidemiology of early infection. And surely there was lots of angst and concern among particularly the gay community that this is now a government list, and they had every reason to be concerned. Obviously that no longer is an issue as it's now reportable everywhere. But I think the point being is I've dealt with some pretty tough situations, both socially, economically, et cetera, in our outbreaks that we deal with. It wasn't until COVID-19 that I ever experienced my first death threat. And now they're not irregular. If you could read my incoming email, the thousands I get each day, you'd understand how much of an enemy of the people I really am and how bad it is. Over 50 of my colleagues in public health have left their jobs because of the almost terroristic-like lives that are living right now of people who are convinced that this pandemic is not real, that it has been an undue and horrible penalty put into their lives, et cetera. And so I think that one of the challenges we have right now is trying to deal with the political side of this and the rancor and the kind of situation you're seeing now. There's a whole move in the Republican leadership in Washington to actually consider charging Dr. Tony Fauci, a dear friend and colleague, with the fact that it was NIH that made it possible for Wuhan lab to make the virus that did what it did. I mean, it's just crazy. But the point is that this poses a whole new set of challenges. We've never dealt with this before. We've never really seen, maybe a couple of percent of people who we put out there in the fringes. This, in some cases, represents a third of the population. And so if you have that challenge, we aren't really fully prepared, let alone, to solve it, but to even know what to start to do. And this has been a real issue. So I think we probably are in the worst place in the world, but the European countries are seeing some of this, not quite as bad as we do. And this makes the old anti-vaccine crowd, how should I say it, still very relevant, but they're just a small part of this whole big new umbrella that has brought all these different parties together. So I'm not hopeful at this point we're going to have some new magic way to explain to people what it is that they want to hear or want to believe when they don't believe that this is a real problem to begin with. And that has just been a social experiment, you might say, to do in their lives.
Just to switch gears briefly, we have a question from Dr. Treitman, our Division of Infectious Disease Chair. How do you think this past season's lack of influenza transmission will affect upcoming flu seasons? And why do you think we did not see any influenza transmission this past season?
Yeah, That's one of the reasons why I gave the disclosure I did up front, because the more I learn, the less I know. I've been studying influenza pandemics literally for, the last 25 years, including the previous 11 ones. And it's only been in the modern era that we've had the ability to understand what was going on from a virus infection standpoint when the pandemic actually happened. The one that most notable is 2009, where H1N1 emerged in mid to late April. It peaked in the United States in May. Throughout other countries around the world, the same thing happened. We saw a greatly reduced activity in June, July. In mid-August, we saw it started in the northern or the southern states in the United States, spreading to the northern states later, this peak of H1N1 cases. Meanwhile, the same activity was happening in the southern hemisphere, which was now their winter. And of course, we saw our peak occur in very late September, early October. The numbers of cases came down precipitously after that. Vaccine was not here until mid-October. We didn't do anything to mitigate during that time. There was no closing of anything, no masking, no distancing recommendations. We didn't have vaccine until the second big wave peak was well down to almost nothing. So that one gave us an opportunity globally to look at that, and the same thing happened. H1N1 pandemic virus took over. We saw no H3N2. We saw no influenza Bs. We saw respiratory syncytial virus disappear through both the southern hemisphere winter and then our subsequent winter. We don't know why. Well, now fast forward to COVID-19, and the same thing is happening. I keep hearing people saying, well, because we're wearing masks or we're mitigating this. Look, we got a lot of transmission of COVID-19, of SARS-CoV-2 virus that surely by itself couldn't be stopping the transmission of these other viruses. And if you look at both southern and northern hemisphere, it's happening here just like it did in 2009. And so the answer is, I don't know why it's happening. Why would Mother Nature do that? What is it? If everybody was infected all at once with COVID, you could argue that there's no niche area where any of these other viruses could survive. But, it's not happening like that. So I don't know. We looked at the 2010-11 season after having gone through the previous year without evidence of influenza from the 2009 pandemic. And we can say there was only moderate activity for both H3N2, H1N1, and if there was more increased activity for influenza B. So, will we see that in the upcoming winter here for us? It surely is not being seen right now in the Southern Hemisphere. I was on a call just earlier this week done with the group in Brazil, and, flu is just not occurring. The same thing with respiratory syncytial virus, et cetera. So I wish I could give you more information. I can't, other than to say that the observation is right on the mark. We just don't know why.
All right. Just seeing if there's any other questions on Zoom. We're coming up to our time mark, and we want to be respectful of your time as well.
Sure.
Any other questions in the room? No? Okay. Well, Dr. Osterholm, thank you very much. We really enjoyed the talk, and thank you so much for what you're doing on a national and global scale.
Well, thank you. I appreciate the opportunity to be with you. Thanks a lot. Stay safe, everyone.